Hi, my name's Sean. Used to suffer from a disease called ankylosing spondylitis, which is a very debilitating inflammatory condition. Suffered this for 12 years. However, I'm now symptom and drug free, anti-inflammatory drug free, and have been so for the last 18 years. So today I've managed to catch up with Professor Ebringer, who was responsible for me getting my life back, essentially. So I'd like to introduce Alan. Hi, Alan.
Hello, Sean.
Great to see you again.
Nice to see you again.
I've got a few questions for
Yes.
you regarding your studies into the cause of AS. As I'm intrigued to know a bit more about those. So the first one is really, when and why did you choose to study AS, given all the diseases out there?
Well, the reason that I started to study ankylosing spondylitis is that in 1973, Dr. D.C.O. James from the Westminster Hospital discovered that 96% of ankylosing spondylitis patients were the carrier of a blood group called HLA-B27. The frequency of HLA-B27 in the UK population is 8%. There is a huge difference here between 8% in the general population and 96% in the ankylosing spondylitis patients. So Dr. James came to my immunology lectures and asked me, do you know why the majority of ankylosing spondylitis patients have this particular blood group, HLA-B27? And my answer to Dr. James is, I do not know, but I'm prepared to provide a possible explanation in that in rheumatic fever, patients are infected by a microbe called Streptococcus, and 3 to 4 weeks later, they get the heart symptoms because antibodies to the Streptococcus attack the heart valves. I suggested to him that this is what's happening also with ankylosing spondylitis. His answer was, Alan, I will provide you with all the HLA-B27 cells and see if you can investigate this problem. And that is how we started the studying ankylosing spondylitis. What happened next is that we injected rabbits with HLA-B27 from humans who were healthy, and 3 to 6 weeks later, we examined the sera from the rabbits to see which microbes they would react with. And to our surprise, they reacted with a microbe called Klebsiella, which is found in the gut of normal human beings. So our suggestion was that somehow Klebsiella was involved in producing ankylosing spondylitis. Subsequently, we measured antibodies in patients with ankylosing spondylitis, and they had elevated levels of antibodies to this particular microbe, but not to other microbes like E. coli. So far, elevated levels of antibodies to Klebsiella have been found in 18 different countries throughout the world. And this indicates that somehow Klebsiella is involved in causing this disease. Our suggestion is that Klebsiella somehow evokes antibodies, which then produce autoantibodies which attack the collagens in the spine and give rise to backache and spondylitis.
So what are the clinical symptoms of AS?
The main clinical symptoms of ankylosing spondylitis is muscle stiffness in the morning and especially prolonged backache. And it takes sometimes when the patient gets up in the morning to unstiffen himself before he can walk around and feel better. The muscle stiffness is quite severe, and sometimes the patients cannot get out of bed, but they have to roll out of bed.
I guess that would also be accompanied clinically with alleviated ESR and CRP.
Yes, the biochemist. The ankylosing spondylitis is an inflammatory disease. Inflammation means that various components of the inflammation are elevated in the blood. One of them is erythrocyte sedimentation rate, the other one is C-reactive proteins, and these are elevated in patients who have severe ankylosing spondylitis. So we have an objective way of measuring inflammation in patients with ankylosing spondylitis during a relapse in their disease.
Just in terms, just going back to with regards to the link between HLA-B27 and Klebsiella.
Yes.
I understand there's a process called molecular mimicry that takes
Yes.
place. You able just to explain?
Well, molecular mimicry, if it started, was discovered in the 1960s in rheumatic fever, where there was molecular mimicry or molecular similarity between the antigens present in Streptococcus and the antigens present in the heart valves. So the antibodies produced against the Streptococcus couldn't tell the difference whether they were sitting on heart valves or whether sitting on the microbe itself. And in presence of the inflammation, they cause deformities of the cardiac valves, and is how you got rheumatic fever. In ankylosing spondylitis, there is molecular mimicry between various collagens as well as HLA-B27, and the antibodies attack cells who have HLA-B27 and also the collagens that are present in the spine. When the antibodies are very active, the patients will feel pain, and one way of treating this is anti-inflammatory drugs. But as well as using anti-inflammatory drugs, we should also reduce the quantity of Klebsiella in the gut so that the patient does not produce high levels of antibodies against this microbe, so that the antibodies produced will not attack the spine. And one simple way of reducing the bacteria in the gut is to reduce the substrate on which they grow. And the main substrate on which they grow is starch, bread, potatoes, cakes, pasta, and rice. So if we reduce these components of the normal human diet, the patients will have less Klebsiella, therefore there will be less antibodies, therefore there will be less autoantibodies, which will attack the spine.
Can I ask you, Alan, why it's so difficult to get a diagnosis? Because from my own point of view, it wasn't until I met you some 10, 12 years later that I finally was able to get a diagnosis. Almost everyone I saw had given me a different diagnosis. I think I was probably diagnosed with having perhaps 10 plus different kind of arthritic type diseases. So why is it so difficult to get a diagnosis?
The reason why it is difficult to get a diagnosis is that this refers to a fundamental medical problem. When you have a disease, at the beginning, you only feel unwell, and it takes some time with other features of the disease will appear, so that will manifest themselves, so that you can get a diagnosis. So, for instance, many of the patients who have problems with ankylosing spondylitis initially felt that they had growing pains, or that they had difficulties because they played sports too much, and they did not realize that this may have been linked to a genetic component in their background. So it always takes some time to make a diagnosis, and once you have too far gone, once the disease has developed, you want to catch it early before the patients get permanent changes in the spine, and therefore you want to catch the patients with tuberculosis before he dies of complications of tuberculosis. So you want to treat them as early as possible, and the same applies to ankylosing spondylitis. You want to treat patients who feel unwell, who've got an elevated ESR, who may have some backache, but a diagnosis has not yet been achieved.
Why is the stiff lower back so evident in AS patients?
Well, the lymph nodes that drain the gut are actually stuck on the front of the lumbar spine, so they're very closely related to the anatomical site which gives rise to backache. And every time you cough and so on, some of these antibodies will move into that area and activate the collagen components of the spine and cause inflammation. However, I must remind you that patients with spondylitis also have uveitis, have eye problems and also have problems with the rib cage, so that it's not just confined